So if it's okay, then we can move on. I am going to give the next talk, and just allow me to share my
Thank
screen.
you.
Thank you, Saurabh. Thank you. So what I'm going to do here in the next 30 minutes is to run through some of the things that we found from the literature review in our project. So I'm going to let you know how it's quite an enormous task, and it took me and a few colleagues quite a lot of time over the past year to complete this. But we would happily receive any comments and any questions you may have towards the end. I've not acknowledged all of my colleagues here, but we have done this as a team. So declaration, again, like previous speakers highlighted too, we've received this funding from the WHO Kobe Center. It's a little bit about our project. It's a free domain study. So what we have is the literature review and the case studies that we've seen. Together, we are going to draw evidence for expert consensus research. And at the end, we're hoping to have our policy brief to the various Ministry of Health around the world for recommending how to prepare our workforce for HEDRM. So the reason why we have all these case studies and literature review is that it's very important for us to review what evidence is available so that we can draw out these recommendations. And at the moment, we are still in the process of recruiting experts, panelists, and we are hoping to start the modified Delphi study in June. So please let us know if you have any comments or any recommendations on any of the cases that we've talked about. A lot of these will be published and they will be available in the journal format, manuscript format. But at the same time, we'll try to make these resources available for at least our panelists so that they're familiar with what's been done. So again, a call for your involvement if you're interested. So what we're going to talk about, it's mostly focusing on the HEDRM. So again, I've mentioned this in the morning, but in previous disaster response or disaster preparedness strategies, it's mostly event-based, reactive, and focusing on a single hazard, single agency. But now with HEDRM, we're hoping to move to a proactive, risk-based, multi-hazard, vulnerability and capacity focused approach. So it is really a paradigm shift, and hopefully to get you all to join us in promoting this concept, which is very important. So let me jump straight to the methodology in view of time. We've done a scoping review for the literature from 1990 to 2020. So we've done according to the scoping review guidelines. So initially, one reviewer and with full text screening, 2 reviewers. We've looked at 3 databases, including Medline, Embase, and CINAHL. And using the following search terms, which includes the top, mainly speaking, disaster and crisis. And secondly, on the health workforce in the broader scope. Here are our inclusion exclusion criteria. So we only included English in this presentation. Those who suited the definition of disaster and humanitarian crisis and in one of the functions and components defined it in the HEDRM framework document that you may be familiar with. So exclusion criteria includes those that are purely focusing on military, those focusing on a single type of clinical procedure or surgery, those focusing on pure research, and those where we do not have data or full references or full text available. So actually we found quite a number of relevant papers. So we trimmed down from 8,000 odd papers to 355 for the full text screening. And then we found 103 relevant articles. And we are going to divide these papers into 3 sections so that you get a grasp of what they are because of the wide scope HEDI. So first on the workforce search capacity, just on every bit, we will let you know sort of how many papers, where these papers are coming from, and sort of what methodology has been used and what hazards that we are talking about. So for the availability of healthcare workers, we're going to start from the availability of personnel. So we have seen from many previous disasters that health workers are not able or not willing to return to work because of the restrictions. So, and we've seen that some of these studies reported on hypothetical disaster situations. So these surveys go out to personnel asking if, such as and such of disasters happens, or will you be willing to report to work? And other studies reported on the real disaster outbreaks and reported on the number of staff that actually returned to the workplace. So just you can see the range of proportion here from 7 to 97% in hypothetical situations, but also 22 to 67% in real actual disasters. Looking at these factors, we've seen some modifiable and non-modifiable factors. So people tend to be more willing to return to work in natural disasters. Men, they may have more capacity, maybe I'm stereotyping, in some settings where men does not have to take care of their family members, they may be in a better situation to return to work. Other factors including training, that's something that we'll come back to. Childcare, family preparedness, support issues, that's something that we've alluded to. And there are other workplace factors, including leadership, their availability of PPE and vaccination, especially in pandemics, and also their perceived role, whether it is important. So a range of factors there with a range of odds ratio we've seen. So these are important lessons that we have learned, and we'll be reporting our recommendations a little bit later on. Putting it into graphical illustration, so we've seen that natural disasters are where we've seen more healthcare workers are willing to respond, followed by pandemic, influenza, CBRNE events, and then SARS. I mean, in SARS, interestingly, we've actually seen a number of healthcare workers not able to return to work. And I think that study we found is probably not the only one. But there is also a range that we've seen with different healthcare settings. So we were trying to see, which of these factors are more important and what can we do about them. So for example, the Amtrak study that we've quoted here, the level of knowledge is actually seen to be very important in terms of the willingness to return to work. Other studies reported family responsibilities and whether they would pose hazards or threats to their family's health and safety. So that's something that we need to be aware of. So I'll come to our recommendations later on, grouping them into the whole workforce search capacity. Looking at deployment issues, there are 10 papers coming from a variety of sources. Again, we've seen volunteers that are coming in spontaneously in studies from Sudan and other places. And sadly, we've seen, governments terminating these volunteers because of the unregistered entity. Even though nowadays we see a lot of social movements on the social media, a lot of people responding, but I think it's essential that we are aware of what issues in terms of legal responsibilities and also the standards and the training and the protection issues. So it is an opportunity, but also there are threats into these spontaneous volunteers. So a study in 2016 poses that actually a lot of them said that, authorities have said that, they are both a resource and a challenge. And actually some of them said that it's more of a challenge than a resource. So if they're not managed well, they can be something of a problem because they certainly do require resources for coordination. So in terms of hospitals that have seen unfamiliar medical volunteers, they normally are placed into non-clinical roles and in the non-acute setting. So again, if these volunteers are not pre-registered, are not assessed, it's very difficult to include them in the high-risk areas or the more clinical aspects. So something, again, we've seen to be an issue. In terms of the protection or other barriers, so there are legal responsibilities. So there are legal consequences that volunteers may not be aware of. There are previously lawsuits reported in certain countries. And also there are injuries or even deaths with volunteers, sadly. So it is a real threat and real issue that we have to be aware of. And some have suggested, training and perhaps just-in-time training. It's something that we are increasingly looking into. And in some cases, like in the United States, the Medical Research Corps, MRC, are doing something proactive since the 9/11 attacks. Lastly, looking at the on this domain, looking at the internal, external as a search capacity, we've seen that papers from Ebola or other hazards that credentialing is important because of the potential restoration or the legal issues that we've seen, and Sachin alluded to that for the Syrian healthcare workers working in Lebanon, whether whether it's legal, whether the system can absorb these capacities. So there is a broad push to pre-event registry or government waivers for licensing for the emergency medical teams as led by the WHO. So we've seen a couple of publications talking about those things. On the other hand, standards are very important. So we often unsure of what the level of cares are provided by these foreign volunteers. So we need guidelines and we need training and credentialing, especially on the more culturally sensitive issues like burial that has been raised. in the past. So 3 broad recommendations. There are more recommendations, but just to draw on the important ones, that we need to review the search capacity. So in certain types of disaster, we can expect up to the loss of up to half of the workforce. So we need to address the modifiable factors and remove the barriers so that people are willing or able to respond in disasters for healthcare professionals. But at the same time, I think we need to, because of the surge in workload and increase in capacity that is necessary, we often need to be looking into volunteers. So when we look at volunteers, we need to look at their legal protection, the medical protection, and their standards and training, for example. So often pre-registration or establishment of a mechanism is often needed, and spontaneous volunteers are increasingly seen to be an issue. Often we hope to be engaging people before in peacetime, so before disaster occurs. And there are standards developing and best practices that can be shared from the literature review about not only domestic but also foreign workforce training. So looking into the workforce training issues, that first we look at the competencies and the curriculum that has been reviewed. Actually, that there's been quite a few systematic or scoping reviews that has actually been done on this topic. But here we included original papers that focus on the range of aspects, but more on multi-hazard approach. So we've seen a lack of recognized competencies across hazards and across different personnels, understandable given the diverse knowledge base. But in HEDRM, we very much hope to tackle this issue and standardize what is needed across hazards and across professionals, but adding on to specific domains where necessary. So most of the competency frameworks we've seen that include the broad general system-based knowledge, as well as specific skill sets, which we've alluded to. There is a need for a clear recognition of the role and function so that they can prepare for it, and members are aware of what potential role, what they are expected to serve during disasters. So that's, again, very important for people to be mindful so that they know what exactly they're expected to know. And again, an observation seeing that a lot of the competencies are focusing on the response phase. So we need much more of a preparedness or hazard or phases approach, so as to be able to, people are able to continuously prepared for, respond to, at the same time build back better, as we've seen from the talks yesterday. On training itself, there is a lot of experience. Just to highlight some that has been raised, especially on the different modalities. So we have seen a lot more, especially during COVID-19, and this virtual symposium, it's a great example. There are materials that are suited or suitable for web-based learning. So a lot of that can be done online for wider dissemination. But where specific skill sets are necessary, often we need multi-modalities training. So some blended approach can supplement to these online courses. For example, we've seen practical skills where hands-on workshops are very important, and in other aspects where tabletop exercises, or as Luca has alluded to yesterday, that we need full-scale exercises for our particular skill sets and communication. So that we're going to go into a little bit more later on. And some studies actually pointed out that there is very poor knowledge retention. So we've seen from different studies actually on clinical topics yesterday that the knowledge start to deteriorate even within a year. So we need frequent refreshers, and especially during, in the wake of a disaster, because I think it's difficult to provide, real-time, face-to-face refresher course when we are actually responding to emergencies. So often we can be planning for these just-in-time training and maybe providing them in an online format where people can access these information right away whilst they are referring or responding to these emergencies. So it has been advocated as one of the successful stories in filling this knowledge gap. Leadership, it's increasingly an important competency or aspect that we are looking into for not only in management, but also in terms of training and structures. So we've seen leadership theories that supports various leadership competencies framework during crisis. And we have a lot more sort of courses on decision making, like crisis decision making, making us aware about the mental load that we have. Leadership theories, including the Federers, and also a few on the structure interaction between, the leadership and the environment, how to motivate the team and provide a more trusting and inspiration leadership in terms of responding to crisis. So a lot of these research are done before COVID, but we've seen that this can apply equally to the COVID-19 response. So highlighting the importance of the all hazards and drawing lessons from the literature. Situation analysis, I think it's something that has been increasingly talked about. We know that having the knowledge and experience of an individual can make someone make better decisions. But at the same time, I think how to integrate the real-time data or the information aggregate that can provide a sort of a mental picture that takes care of statistics and real-time information to allow these informations to be used for decision making. It's something that has been increasingly emphasized. So in terms of recommendations for this aspect, we are recommending a comprehensive risk management approach. And increasingly, I think previous authors have pushed for a curriculum that is well accepted, but we need this, especially taking into the HEDRM perspective, including the all hazards approach, including the system-wide all responders approach that is risk focused. So again, this has to be incorporated in our future training, especially in the curriculum, so that we can guide our future training where necessary. Secondly, we need this to develop better online learning tools and to be able to differentiate what needs to be supplemented and how to ensure that knowledge and retention, it's there, perhaps how to use just-in-time training as we've alluded to, but how to implement these in the context of various individual health systems. It's also important to include these decision-making and leadership knowledge so that personnel can include these whilst they are doing their job in managing these disasters and doing communication. So lastly, on the health system and coordination aspects, so for communication, we've included 7 papers, mostly on outbreaks. We've seen a rise of social media and internet resources that's even pre-COVID. I think a lot of you may be aware of. So for the younger generation, social media, it's something that people are very engaged and in tuned into. And there are papers highlighting training that has been done to train the Ministry of Health and the health workforce on how to maybe disseminate this knowledge into the least English proficient groups. So for those minority groups or those who may be more vulnerable because of the language capacities and information gap. So training like those has been very successful and has been recommended by authors in the literature. Also, other papers suggested that we need to make sure that the community partnership is there. So GPs, our personal network, personal resources are very important. Not only in the Western medicine setting, but sometimes we even need to engage the traditional health partners. So whether we have the traditional local practitioners where, like in Hong Kong and in China, where we have the traditional Chinese practitioners, they may actually be key stakeholders that we want to engage for this communication. On the issue of misinformation, we've seen this firsthand during COVID-19. Delivery of accurate, credible source of information is very important, but a lot of studies found that actually is not being done well. So taking an example, a lot of these, some of these papers looked at the US CDC websites and found that it's actually difficult for the low literacy groups, and probably there is a need to emphasize, the use of figures and graphical information. There is a need to raise awareness in the beginning so that people can be engaged. And also the issue of information overload. This is something that has not been recognized because there is a certain information time span. If you will want to include a lot of information, people may suffer from information overload. So messages needs to be aligned and provided by a trusted source so that people can get a coherent picture. In terms of good public communication, we've seen that authors suggested that these are essential because they can actually save lives by advocating behavioral change in communities. But there's actually a lack of formal evaluation. So we need more clear evaluation of how these messages can be most effective. And hopefully COVID will bring us more evidence on these fronts. But we've actually also seen at the same time, actually healthcare providers can also be easily experiencing message overload. So we just need to be mindful. In terms of hospital preparedness, I think Sora point to a lot of these and exercises that we've mentioned about. So the use of exercises are important, but we need to be mindful of the quality as well. So Luca point to the full-scale exercises that provides a comprehensive approach. They're good, but they may be costly depending on your jurisdiction or your setting, how familiar you are. Tabletop exercise can provide good coordination, test SOPs, provide relationship building, and clarify on decision-making structure and problem-solving issues. So good for system-wide issues. We often see the need for working across jurisdictions, across borders. So information sharing can be a problem for security-related matters, but we need to open up for a shared frame of reference so that people can have a common structure. So jurisdiction has to work, with each other. And we've seen from radiological events that, there is a good scientific registry coordination mechanism. So from a Cremidin team that we've seen actually people recommending practitioner networks that stimulate the required attention, and maybe with a central registry of personnel. with special responsibilities. Hospital exercises, we've heard from Saurabh about the NDMA with the data sharing and hazard maps, providing emergency structures with the national incident management systems. But that has to be taken across the public health spectrum because public health workers actually different to the security personnel. They may not have the same structure, terminology, and jargons that's seen in the literature as well. So Saurabh has mentioned about the guidelines, so I'm not going to highlight too much, but there are a push towards hospital incident management system rather than the incident command system that's seen in an experimental study. And lastly, towards the legal system, we've seen that the definition of disasters, the jurisdiction for health workforce volunteers differs. Some governing bodies may not have the right to declare emergencies. Some public health workforce may lack insight to the legal triage, especially regarding pandemic situations, school closures, economic balancing with the community and safety mechanism. So there is a lot that we can learn in using exercises or different tools to triage. We need to avoid harm to our beneficiaries or our victims when there is a disaster. So we don't want health volunteers who are practicing out of standards, but at the same time, we do not want to stymie the public health interventions because of fear of litigation. So that's something that we can work towards during the peacetime again. So lastly, the recommendation on the last domain, we need updated training on communication modalities, both with the traditional and the social media communications. So we need workforce that are equipped with skills to design the messages and supplemented by appropriate graphics. Tabletop exercise can be useful, so that may be something that we can consider to test our system. National standards are needed, and especially with the recommended hospital incident management system that can work, possibly with the urban-rural divide we've seen with some in the rural hospitals settings, they can be a real gap that we can see. Volunteer systems need to be set up and undergo a legal review so that they can function properly during emergencies, and legal triage exercise can help collaborate. So the policymakers and also the public health workers can work together so that to prepare for the different scenarios that may unfold. So I know I'm running a bit out of time. My concluding slide is that we have provided an attempt to extract data systematically from using the HEDRM components. Mainly they are data synthesis. We have not yet performed meta-analysis. I think for some of them, we can attempt to aggregate these in a more quantitative way. We have seen very different level of evidence, but in general, there are very few experimental studies that are available. We have provided some anecdotal evidence and some recommendations based on that, but they are yet to be seen whether they can be applicable to, for example, low middle income countries as well as high income countries, and across different health systems and across multiple hazards. So we are finalizing these recommendations. So Marky and I will have a lot to do to have to work with all of you to finalize these recommendations to proceed to our next phase, the expert consensus research. So do get in touch with us if you have any comments regarding these recommendations. I know that there's been a lot that I've tried to cover, and they're only part of what we found. So if you're interested also to join us as an expert panelist, so we will have that information available perhaps in our website, the criteria for joining as an expert panelist, but do email us if you have any questions or concerns. So that's all from me. And I think that we have a message from Rauma, so that before we conclude the session about research gaps and directions. But I think Colin has something that you want to ask. Yes, Colin.
David, thank you. Great talk, as always. Just a quick question, really, just to, as I was listening to it, and obviously I've been involved in this, but it struck me that, especially when you talk about surge capacity, you know, in the developed world, we often run at more than 100% of capacity in healthcare facilities, and Hong Kong's no different than many other places. But when that bed use is always as high, how much do we need to engage with the managers? I mean, our research has predominantly been with healthcare staff, as in clinicians, doctors, nurses, professions allied to medicine and healthcare. But is there anything out there that you came across that looked at engaging with strategic managers, for example? And I'm thinking of the tension between, you know, well, why would you ever run a hospital at 85% capacity when you could run it at 100%, particularly if there's a financial element involved, which we see in so many countries nowadays? Just curious if you came across anything like that, and if not, should we be?
Yeah, so thanks, Colin, for the question, and it's a very useful one, I think. So unfortunately, from our search, we have not come across any that focuses on, you know, whether our health system should have reserve in the routine setting. But I think there are a few relevant things that I, due to the limitation of time, I've not included in my presentation. So there has been some emphasis on how to make beds available during crisis. So a lot of hospitals have discharged patients that may be able to go home or go to alternate facilities. And emergency departments may be able to turn away patients that may not need emergency services during those times of crisis. And obviously, we, not so much from literature review, but we've seen a lot of talks about the crisis standards. So during crisis, we may have a different standard of care. Because the aim is to make sure that we have the best use of resources for the most number of people. That's probably different from how we normally operate in peacetime. So I think all that needs to be discussed pre-disaster, so that, for example, our medical protection can allow us to, you know, practice during those times. And, you know, we can be discharging patients that may not normally be ready to go home. But at the same time, I think, you know, we've seen from Saurabh's presentation and others as well, saying that we need mechanisms to bring in resources. And there is a mechanism for people to switch into the coordination mode, you know, once we have the alert, or nowadays with the early warning system, as we've seen with the storms that across the world, I think we can actually be preparing for these events days before it actually happens. So I think you've brought a very interesting and important issue, and I think in Hong Kong we're not immune, and part of the job for the community, the work that we've all been involved, is how to raise awareness and get this preparedness, so that we can be preparing for future crisis.
Thank you.
Thanks, Colin.